Hello, my name is Dr. Noble Jones. I'm the program director of inpatient cancer rehabilitation at Emory University. I'm very excited to speak to you today about musculoskeletal disorders in breast cancer survivors. We're going to give you an outline of today's topic. We're going to talk about breast cancer in Latin America and the Caribbean. We'll follow that up with shoulder dysfunction and the different complications a patient may experience. We'll wrap up that with aromatase inhibitor-associated musculoskeletal syndrome, and finally give a case presentation to hopefully tie together some points. So breast cancer in Latin America and the Caribbean. Breast cancer is the most common cancer and most common cause of cancer-related deaths in women in the Americas. It affects 1 in 3 women under the age of 50, and it is responsible for 50% of cancer-related deaths in women under the age of 65 in Latin America and the Caribbean, compared to 37% in North America. In 2020 alone, there were nearly 68,000 deaths related to patients diagnosed with breast cancer in Latin America and the Caribbean. There are a lot of musculoskeletal complications that can occur as a result of breast cancer treatment. In fact, these complications affect over 50% of the women who undergo some type of breast cancer treatment. These complications include post-surgical pain, rotator cuff disease, bicipital tendonitis, adhesive capsulitis, bony metastasis, epicondylitis, decoy veins, tendinosynovitis, arthritis, myalgias, and all can have an overall decreased function in activities of daily living, as well as decreased quality of life in the patient. And in some cases, these symptoms may actually mask recurrence of cancer. So it's important to rule out metastasis or new neoplasm whenever a patient presents to clinic, especially if their pain is out of proportion to their symptoms. So let's talk about post-surgical pain. Tumor resection. So the surgical method used plays a very, very, very important role in determining the shoulder dysfunction after breast cancer surgery. The less involved a surgical procedure, such as a lumpectomy or a partial mastectomy, the lower the risk of developing a shoulder dysfunction type picture. The more involved procedures, such as modified radical mastectomy or radical mastectomy, which involves removing the breast tissue, the fascia, nipple, skin, pectoralis major and minor muscles. Those more involved surgeries have an increased risk of patients developing some form of the shoulder dysfunction. Additionally, the more lymph nodes removed also increases the risk of these postoperative morbidities. So the more involved the procedure, whether it's the tumor resection or axillary dissection, the higher the risk of developing shoulder dysfunction. In addition to tumor resection, breast cancer reconstruction also has an increased risk of patients developing shoulder dysfunction. Common procedures that you may see in clinic are tram flaps, which is the transverse rectus abdominis myocutaneous flap procedure, where this includes the rectus abdominis muscle being repositioned underneath the removed breast with overlying skin and blood supply. If the resection or the flap is pedicle, that means it remains in contact, the blood supply remains intact, and the muscle is tunneled under the skin. If it's a free tram, then the muscle, blood supply, everything is completely disconnected and then reattached in the surgical site. where the breast was removed. Deep inferior epigastric perforator flap procedures transfers fat from the lower abdomen as well as the blood supply and place it over the resected tissue or used to reconstruct the breast. And then a latissimus dorsi flap, which uses muscle and overlying skin from the back to reconstruct the breast. Now you can imagine all of these things are very, very involved in rearranging the anatomy. So the shoulder biomechanics or motion or the biomechanics of the shoulder are going to be compromised, which increases the risk of shoulder dysfunction in the patient. In addition to the autologous implantations, you also have tissue expanders that may be implanted in the breast at the time of the mastectomy to slowly stretch the overlying skin and the musculature in the chest wall. And this can be placed underneath the pectoralis major muscle, and then over the course of 4 to 6 months, saline is injected gradually over time to stretch the tissue and the muscle. This also can cause pain and discomfort, as well as changes to shoulder biomechanics in the patient. So postoperatively, if you are seeing any of the patients, whenever they're complaining of pain, discomfort, chest wall tightness, it's always important to rule out the dehiscent seroma infection or tissue necrosis. During physical exam, since it's so soon after the surgical procedure, the strength is often limited by pain as well as the range of motion. The patient may have some tenderness to palpation during the exam as well. But it's important to do a very thorough exam. If untreated or not diagnosed early and treated, shoulder dysfunction can result in a rotator cuff pathology, such as adhesive capsulitis, which we'll discuss a little bit later. So how do you manage post-surgical pain? Well, you want to manage it before it starts. Studies have shown that if you prescribe the patient prehabilitation or preoperative exercise protocol, it can improve their upper extremity recovery. This involves twice a week of exercise, 1 to 2 weeks prior to surgery. The goal is to optimize the shoulder range of motion, grip strength, and general fitness level of the patient. And then after the procedure, studies have shown that if you mobilize the patient's upper extremity 15 days after the surgery, they have better upper limb outcomes than patients who are immobile until 30 days after the surgery, which is pretty common in a lot of clinical settings to immobilize the patient's upper extremity for 30 days. But the rehabilitation exercises should be implemented in both upper extremities as well. Conservative treatment is always going to be the mainstay for treating this shoulder pathology, which is therapy and exercise. Opioids acutely after surgery or postoperatively is often the go-to before transitioning to NSAIDs. But over time, patients should be weaned off of opioids and onto a more conservative approach for managing pain. Studies have even shown that ultrasound-guided erector spinae plane blocks after mastectomy have had favorable benefits in reducing postoperative opioid use in patients. Adhesive capsulitis. So, adhesive capsulitis, also known as frozen shoulder, is a complication when the synovial tissue of the capsule and the bursa, here's the capsule, become adherent. Patients will experience reduced active and passive range of motion, and they'll have some stiffness in the glenohumeral joint and pectoral muscle tightness with pectoral muscle tightness. And this can lead to rotator cuff disease if not treated due to changes in biomechanics of the shoulder girdle. There are three distinct phases of adhesive capsulitis. First stage is the painful freezing stage, and this will begin 2 to 9 months after the surgical procedures. And patients will complain of sharp, diffuse shoulder pain with some stiffness. And as it worsens, the shoulder freezes, range of motion and stiffness are at their peak loss, or stiffness is increased and the range of motion is lost. And this could last up to a year. And then there's a third and thawing stage, which can be start anywhere between 5 months after onset to a couple of years after, maybe even longer. And patient will gradually regain their range of motion. But it's important to treat this because these patients are also at risk for developing disuse atrophy and osteopenia in the muscles. Risk factors for developing adhesive capsulitis include aromatase inhibitor therapy, axillary lymph node dissection, breast reconstruction, lymphedema, and age. So how do you evaluate these patients? So first, get the history. When did the symptoms begin? And how severe are they currently? And then physical exam. There's pain with a significant reduction in both active and passive range of motion. Patients typically first present with external rotation and abduction range of motion loss, and it'll eventually develop into shoulder flexion, adduction, and extension range of motion losses. It's important to measure the shoulder range of motion in all directions. These patients typically will have less than 15 degrees of external rotation, and they'll also have early decrease in scapular motion. X-rays are typically normal, but can rule out tumor or calcium deposits. Osteopenia may be seen on imaging. MRI will show some thickening in the glenohumeral joint capsule and synovium, but it's really not necessary to get an MRI to diagnose this condition. So how do you manage these patients? Treatment is always going to focus on improving range of motion and controlling pain. You control pain with oral meds such as NSAIDs or acetaminophen. That's going to be your primary first line of treatment. You can do corticosteroid injections directly into the glenohumeral joint. It shows that it does alleviate pain and improve range of motions in the short and long term. And it can be very effective in alleviating pain prior to the start of physical therapy so that the patient can get the most benefit out of their therapy sessions. Once in physical therapy and doing an exercise program, improving range of motion and overall quality of life is the goal. This can be done with progressive banded strengthening exercises as well as scapular stabilization maneuvers, which showed improvement of shoulder range of motion. And then other interventions which may be used later in the treatment course could be hyaluronic acid and platelet-rich plasma injections, hydrodistension using sterile water, about 20 to 30 milliliters, injected directly into the joint capsule, as you can see in this image on the right. You can see the distension of this capsule after the sterile water is injected. Other treatments include extracorporeal shockwave therapy to try to break up that tissue, low-level laser therapy, intranasal calcitonin spray for pain management, and then manipulation of the shoulder to break up the fibrotic tissue under general anesthesia can also be helpful. But surgery in general beyond that should be considered as a last resort after a patient has failed all other treatment options. So rotator cuff disease, the next complication we will discuss. Rotator cuff disease is just common in the general population, but is even more so in cancer patients, especially the breast cancer patients. Rotator cuff muscles include the supraspinatus, infraspinatus, teres minor, and subscapularis muscles. Injury or disease in any of these muscles can be a result of changes in the shoulder biomechanics, which may be caused by pain or the surgery or radiculopathy secondary to radiation treatment. Common types of rotator cuff disease include rotator cuff tendonitis and tendinosis. If untreated, this can evolve into a partial or full thickness tears. Shoulder impingement, the patients will experience pain and symptoms exacerbated by overhead activities. And internal impingement, where the tendons of the rotator cuff encroach between the humeral head and the glenoid rim, versus external or subacromial impingement, where you have mechanical or physical encroachment of the soft tissue located within the subacromial space. So how do you evaluate these patients? It's going to be just like you would evaluate any patient in the general population, but detailed history is important. And getting a complete assessment of the patient's symptoms are going to be necessary to and critical to help guide the physical exam. You want to measure the active and passive range of motion of the muscles and the strength, along with a combination of the special shoulder exam maneuvers, such as the Hawkins impingement test, Neer's impingement test, empty can test, drop arm test. Those things are very important in helping to identify whether you have actual muscle tears or partially or full thickness. And also, an accurate physical exam is extremely important into diagnosing the rotator cuff pathology and guiding the physical therapy and additional treatment options. So how do you manage? I mean, imaging is always beneficial to help confirm what you find on physical exam. But ultrasound is just as diagnostically accurate as MRI or MRA for diagnosing full thickness tears in rotator cuffs. In many cases, imaging is really not necessary unless there's an acute trauma or a history of a trauma that has resulted in the patient's symptoms. Medications, acetaminophen is the first line, and then topical and oral NSAIDs can also be used in patients who have good kidney function or do not have any gastrointestinal disease. And then you have corticosteroid injections, which may provide some short-term relief, but is not the first line treatment. It increases the risk of re-tear of rotator cuff injury as well if there's a previous rotator cuff tear. And opioids are not recommended for pain management. You can do PRP or hyaluronic acid injections, but they show some limited supporting evidence of their efficacy. Pain management can be done with a variety of ways, such as manual therapy, therapeutic ultrasound, proprioceptive taping, using TENS units, pulse electromagnetic fields, etc. These things can help the patient, but they vary in efficacy from patient to patient. So now let's talk about scapular dysfunction. So scapular dyskinesia or dysfunction is a physical impairment and alteration of scapular position and motion. It's often secondary to a nerve injury, whether it's the lone thoracic nerve or the spinal accessory nerve. And it can cause impairment in up to 84% of cancer breast cancer survivors, which results in reduction in shoulder and upper extremity function and activities of daily living, worsening quality of life, delayed return to work. And it can also present in rotator cuff disease, impingement syndrome, glenohumeral instability. So scapular dysfunction can go hand in hand with other shoulder dysfunction pathologies. Scapular kinematics may also differ based on the type of surgery. For example, patients who have undergone mastectomy typically will present with internal rotation of the scapula, versus patients who have undergone reconstruction will have a higher upper scapular rotation. So evaluating these patients in clinic, it's important to understand the motion of the scapula with certain arm movements. Patients may present with anterior shoulder pain, superior shoulder pain, proximal lateral arm pain, or posterior superior scapular pain, or some combination of all of those symptoms. But you want to evaluate for scapular weakness. For example, a scapular that's winging both medially and upward would suggest serratus anterior weakness, and this is caused by a long thoracic nerve injury. Conversely, scapulas that wing laterally and downwardly may be due to trapezius muscle weakness, and this is caused by a lesion on a spinal accessory nerve. So managing patients with scapular dysfunction should have the goal of restoring scapular retraction, posterior tilt, and external rotation. And this can be done with a variety of exercises to increase flexibility in the pectoralis minor, as well as external rotation and posterior tilt of the scapula. Stabilization exercises based on stretching and strengthening should be also a significant component of the therapy the patient receives. And patients are safe for doing both closed and open kinetic chain exercises. Axillary web syndrome, also known as cording. So, axillary web syndrome is the development of a painful rope-like band in the armpit. Patients typically report tightness in the chest, arms, and pain with movement and restriction in movements due to this pain. It develops as a side effect of sentinel lymph node biopsy or axillary lymph node dissection. Studies have shown that you increase the risk of developing cording with more involved lymph node dissections, such as axillary lymph node dissection. Often it's confused with scar tissue at the site of surgery. It's important to know that developing cording does not necessarily lead to lymphedema, although the etiology of lymphedema and cording may be the same, such as axillary lymph node dissection. They commonly develop 2 to 8 weeks following a breast cancer-related surgery, but can occur as late as months to years afterwards. The incidence rates can vary as well, from 6 to 86% of patients who have undergone some type of breast cancer-related surgery. So cording can start manifesting with just tightness in the chest and the arms. Patients will report pain and movements. On physical exam, you may actually see the cord in the armpit region, and it'll resemble a tight rope-like structure. It can be a single cord or multiple cords. It can originate in the axillary region and extend down the arm or across the chest wall or breast or abdominal region. Patients will have restricted range of motion in the upper body or the upper or the arm that is the site of the cording. especially at the shoulder or even an elbow movement if the cord has extended down the arm. Now, moving the shoulder into a maximal abduction position can make the cords appear more evident, like on the previous slide here. So how do you manage cording? Physical therapy with myofascial release is critical. You want to improve the flexibility of the shoulder, improve the strength, improve the range of motion, and ability to abduct the affected limb. Soft tissue mobilization and cord manipulation are very important, but it should be done using gentle manual techniques, not aggressive. And pain can be managed with NSAIDs. And opioids may be beneficial for breakthrough pain, but should not be the main source of pain control. So let's talk about radiation fibrosis now. So radiotherapy is used to treat approximately 50% of all cancer patients. Radiation can cause a progressive, irreversible tissue sclerosis in healthy tissue exposed to radiation. There are two mechanisms. There's direct injury from the radiation beam, which causes damage to the DNA, and it triggers cell death in not only the cancer cell, but in a healthy tissue that's exposed. And then you also have indirect injury due to radiation. The radiation caused the formation of reactive oxygen and reactive nitrogen species, which triggers the inflammatory response. And this leads to recruitment of fibroblasts. The fibroblast then goes and deposits extracellular matrix components to the surrounding tissue. This condition is progressive. It starts shortly. Within months, you can see symptoms of radiation fibrosis after their last dose of radiation, but it progresses throughout the remaining patient's lifespan, and it worsens. So radiation damage to muscles within the radiation field can lead to muscle fiber fibrosis, and replacing muscular tissue with fibrotic tissue leads to progressive weakness, spasms of the remaining viable muscle and supporting musculature, as well as pain, and then contracture. And this can complicate other conditions such as adhesive capsulitis or rotator cuff tendonitis and myofascial pain. Radiation damage to the peripheral nerves can also be a result of not just direct damage to the nerve, but even the supporting vasculature. The radiation causes intimal wall thickening of the vasculature, which, as it thickens over time, cuts blood supply or reduces blood supply to viable nerves. This can result in mononeuropathies involving dorsal scapular, suprascapular, or long thoracic nerves, which can contribute to shoulder dysfunction, as well as cause neuropathic pain and muscle spasms. Clinical evaluation, knowing the patient's treatment history is paramount. Knowing the total dose, the number of doses per fraction the patient received, and then, if possible, working with radiation oncologists to review the isodose curves to see what structures were in the field of view of the beam, of the radiation beam. As you can see in this image here to the right, the shoulder, even though it was not the target, definitely has a significant healthy dose of radiation exposure. You want to look on physical exam at the scan, inspect for posture abnormalities in the shoulder, muscle asymmetry and atrophy, skin changes, and even radiation tattoos to see, what structures were exposed to radiation. Then you want to evaluate the patient for weakness, evaluate the reflexes, decreased tone, and sensory deficits to confirm your diagnosis. There's no cure for radiation fibrosis, and the treatment is largely driven by symptoms. So, for instance, if patients complaining of neuropathic pain, then you want to use nerve stabilizing medications such as gabapentin and pregabalin duloxetine, amitriptyline. NSAIDs can also be used when needed, and opioids may be used as well, but they are not the mainstay of managing neuropathic pain. Trigger point injections with corticosteroids or lidocaine can be used to address specific pain generators in the muscular tissue. If the patient complains of spasms, that can be managed with Botox injections directly into the muscle. In this image here, we have ultrasound guided Botox injection directly into the pectoralis minor muscle. And you can also do myofascial release, which has some added benefit to help patients with soft tissue restrictions related to radiation fibrosis syndrome. And then as the muscles become replaced with fibrotic tissues, there are going to be periods where there's going to need repeat neuromuscular reeducation to help improve posture over the patient's lifetime. Surgery is not preferred for any of these issues because the patients typically have decreased tissue vascularization, and as a result, they will have most likely difficulty with wound healing, putting them at risk for infection, tissue necrosis, and other surgical complications. Aromatase inhibitor-associated musculoskeletal syndrome. So aromatase is an enzyme naturally occurring in the body that converts androgens to estrogens and maintains the level of estrogens in breast and bone tissues. Aromatase inhibitors used in estrogen-sensitive breast cancers reduce aromatase systemically, and in turn reduces estrogen. So that's good for the cancer that's estrogen positive, estrogen receptor positive. However, normally estrogen has anti-nociceptive influence or properties. So without this anti-nociceptive property, neurons in the joints or the central nervous system become hyperexcitable, leading to enhanced responses to innocuous stimuli, such as walking or gripping. So patients with pre-existing arthritis tend to have a flare-up of those joints affected. And in general, overall, 50% of breast cancer survivors treated with aromatase inhibitors develop arthralgias in multiple joints. Aromatase inhibitors can be continued for 5 years, but some patients elect to stop or cease treatment due to the severity of their arthralgias. They present with symmetrical joint pain like bilateral wrist pain, hand pain, knees are commonly affected. Carpal tunnel syndrome and trigger finger are common. Other symptoms may include morning stiffness, myalgias, and decreased grip strength. The median time to onset after starting aromatase inhibitors is typically going to be 1 to 2 months, but it can start as early as 2 weeks, and it can be delayed as far as 10 months. Symptoms typically peak at 6 months. So, diagnosis and management. First and foremost, educate the patient on their multi-joint arthralgia as a side effect of the aromatase inhibitors. If they're experiencing mild arthralgias, encourage exercise. Weight loss studies have shown that just general aerobic exercise, 30 minutes a day, 5 days a week, have significant benefits on reducing pain severity. You can also use SSRI therapy in addition to exercise and weight loss to help manage the patient's pain. And then check vitamin D levels. If vitamin D deficient, give 50,000 international units of vitamin D for 12 weeks, once a week. If their arthralgias are moderate to severe, then you can start treatment with a prednisone taper in addition to all these other treatments here. You can also add on acupuncture. Switching to the aromatase inhibitor from one type to another can have some benefit. NSAIDs may be necessary as well. And if these fail, you switch to tamoxifen. But I can't stress this enough, the exercise and the weight loss studies have shown it just has a more significant benefit than many of the other treatment available to the patient. And additionally, it's just a good practice for anyone with or without cancer to exercise 5 days a week for 30 minutes a day, aerobic exercise. So let's talk about our case. So first case, chief complaint. Patient complains of chest wall tenderness and pain in both hands. History. Patient's a 60-year-old woman diagnosed with left breast cancer following the discovery of an abnormality on screening mammography in June of 2015. She underwent bilateral skin-sparing mastectomy on August 4th, 2015 with tissue expander reconstruction. She has multiple areas of tumor, or she was found to have multiple areas of tumor, including a T1C N1A M0 stage 2A carcinoma in the left breast that was ER, or estrogen receptor, progesterone receptor positive, and HER2 negative. She has a second T1A 0.15 centimeter grade 1 infiltrating carcinoma of the left breast, as well as a P1A N0 M0 0.5 centimeter PR positive, HER2 negative carcinoma of the right breast. Her treatment history included 4 cycles of Cytoxan and adriamycin and 12 weeks of adjuvant Taxol complicated by neuropathy. She did not receive radiation therapy, and she underwent replacement of her tissue expanders with silicone implants on February 29, 2016. She has no evidence for disease and from her cancer and is on letrozole. So the reason for referral, she was referred for pain in the fingertips, predominantly in the bilateral thumb and index finger, more than the lower extremities, although she does have some pain in the lower extremities, and some balance impairments as well, which started halfway through her 12 weeks of Taxol treatment and continued to worsen. She also complains of chest wall tenderness and tightness following exchange of implants. Physical exam. So she has status post bilateral skin sparing mastectomies with implants in place. Hematologic lymphatic, she has lymphedema of the left chest wall and upper arm. She has retraction of the bilateral shoulders. She has near normal range of motion, no impingement signs with the shoulder special test, and no significant tenderness to palpation of the pectoral muscles. Her sensation is normal in the distal, upper, and lower extremities, but she has anesthesia in the bilateral T3 to T5 dermatomes overlying the skin or the breast, consistent with her history of breast surgery. She has a 10L sign at the wrist, as well as a positive Phalen's bilateral left greater than right exam. Strength was 5 through 5 throughout the upper and lower extremities, and her reflexes were normal, +2 and symmetrical throughout. Overall assessment. So while the patient likely has some mild chemotherapy-induced peripheral neuropathy in both the hand and feet from the Taxol, I believe she has a more symptomatic in the hands is due to concomitant bilateral right greater than left median mononeuropathy at the wrist, also known as carpal tunnel syndrome, which was found with the Tinel sign in the Phalen's test. Additionally, she has post-breast surgery pain syndrome that's relatively mild, and some lymphedema in the chest wall and upper arm on the left. Again, All of these are just from a thorough physical exam and also guided from your knowledge of her cancer treatment history and possible complications from those treatments. So how do we treat this patient? So chemotherapy-induced peripheral neuropathy with the anesthesias in the hand and feet, and also some balance issues. We want to get her into physical therapy for gait and balance training. For the carpal tunnel syndrome, we want to get her into occupational therapy. So carpal tunnel wristbands that she could wear also. And also we can help lessen the severity of her symptoms with treatment using Lyrica. For the lymphedema, we want to get her into lymphedema therapy. And although not listed in therapy, they will likely give her a compression sleeve for her upper extremity. And for the post-mastectomy pain syndrome, physical therapy with some myofascial release, as well as postural intervention. Things that are fortunate for her is that she did not undergo any radiation treatment for her disease. So she doesn't have the risk of developing radiation fibrosis syndrome. She is on letrozole, so she may develop in the future multiple joint pain, arthralgias associated with aromatase inhibitor induced musculoskeletal syndrome. And that concludes our talk today. I enjoyed sharing my knowledge with you. I hope you can take it to your clinic to help your patients improve their quality of life going forward.